একটু ঝাপসা দেখাচ্ছে তোকে।
আমাকে? হ্যাঁ, হতে পারে।
হুম।
তোমার ওই হয়তো লাইটটা তো ব্যাকে এসো।
হ্যাঁ।
Piyush, you're on mute if you're talking something.
Sorry. Welcome everyone. We welcome you to the intensive Indian Academy of Pediatrics Intensive Care Society and Academy of Pediatrics West Bengal workshop on online advanced ventilation. We're on day 2 now. We also welcome our new participants in the cohort. I'm your host for today. My name is Piyush Goyal and I'm here with my colleague Lakshmi Nair. We are from Day2. Before starting the session, very quickly, I would like to talk about few basics. Please introduce yourself if you're talking. Keep yourself on mute. All the participants are on mute by default. If there's a need, we will give you an option to unmute yourself and speak. We also request you, if you're using a desktop or a laptop, please position your camera appropriately so that we can see you well. If you're at a place which is not good, I request you to turn off your videos. Please also keep your phone on silent. If you have a question, raise your hand, or you can also use the chat feature below. You can post your questions on the chat feature, which we will get directly and will convey to the faculty. Apart from that, we are also going to open our WhatsApp chat box. You can place your questions there also. I request all the participants to just share one main question from their side so that everyone gets a chance, since it's a very big cohort. We also request, if you're sharing a case study, do not take any baby names or any sensitive data about a patient. You can connect to your audio by going below. When you click on this, you get an option of join by internet audio or join by device audio. And you are then connected to the audio in your device. If you want to rename yourself, please go on the participants below. You will get your name on the top. You can use it and rename yourself. Here's our agenda for the workshop. We are on day 2. We'll be talking about ventilator graphics and pulse oximetry and capnography today. As I introduced yesterday, Day2 is a non-profit. We are working on newborn care health. Our mission has always been to improve newborn patient outcomes in India, regardless of where they live or they are born. So we always strive to get the best possible treatment at the place of their birth. We have partnered with Day2, which is also a non-profit, and working on a collaborative model of providing medical education and care management, which empowers clinicians everywhere to actually provide better care to the people right where they live. We have a licensed copy of Zoom. I request all of you not to worry about it. We keep all the systems in place. That's why we request all the participants to have registration process complete and also mention their first and last name. If you're not having your first and last name, and if you're using any of the devices names, we have to keep you in meeting room. A few best practices of the clinics are: please move to a quiet place if possible with the steady internet connection. In case our voice is distracting in between, that might be because you have a bad internet connection. We request you to move to a different room or go outside, which will help you hear the lecture well. We also have a chat feature. Please send me or Lakshmi your messages, your questions. We will then forward them to the faculty so that they can answer you. We work on a all teach all learn model. Every participant is open to share their knowledge, and we also open to learning from other experiences. It's a judgment-free zone. We expect everyone not to judge and should consider every case discussion as a point of learning. A few very basic details. Every session will have a pre and post test quiz, which will pop up on the screen. We request you to please respond to that. It will just take few seconds. Faculty members and co-hosts are requested not to reply to those quizzes. As requested earlier, we'll start exactly at 6. So please try to join us by 5:45, 5:50, so that we can start on time. 75% attendance is mandatory for all the participants. You have to attend at least 12 out of 16 sessions for you to qualify for a certificate. And you should also be there for the 75% of the total time of the session. Our moderator for today is Dr. Vishitrvanu Sarkar, who will be taking you ahead and introducing the speakers for today. We also, like I said, we are going to cover ventilator graphics and pulse oximetry and capnography today. I now request Dr. Vishitrvanu to please unmute yourself and introduce our speaker for today.
To the second session of today's this lecture course. It is indeed a pleasure, a privilege, and honor to introduce and moderate the session of Dr. Ognishekhar Saha. Certainly, Dr. Ognishekhar Saha does not need any introduction, not within West Bengal at least. He is one of the pioneers of pediatric intensive care in Eastern India. Many of the big names in pediatric intensive care in West Bengal today has been his students, and so technically we can say that he's the teacher of teachers, really. He set up the first ever PICU in the West Bengal government sector at Medical College, Kolkata, and has subsequently set up many PICUs across Kolkata, and is currently the consultant pediatric intensivist of Apollo Gleneagles Hospital. As we all know, he has been at the forefront of the pediatric intensive care movement of Eastern India and is the current president of the IAP Intensive Care Chapter West Bengal branch. Now, today's first session is on ventilator graphics. Now, ventilator graphics is a very neglected topic. Most people do not understand what all the scalars and the loops on the display are there for, what they actually mean. But once you begin to understand these graphics, then you will see that it's really easy to use a ventilator. And who would be the better person to teach this essential fundamental of ventilation than the teacher of teachers? So I will now hand over to Dr. Saha and request him to begin his session. But before that, if he could please inspire our juniors by telling a little bit about his training background, please. Dr. Saha.
Thank you, Vijitra, for such a nice, sort of introduction. I don't know whether I'm paid for it or not. Shall I start sharing my screen? Okay, and this is the one, and yeah. Am I audible?
Yes, we will quickly take just 1 minute to introduce the polls, which has questions for both the sessions together.
Together. Okay. Okay.
Hi, Lakshmi, is the polls visible to you?
Yeah, I've just launched the poll.
Okay.
I request everyone to attend it. We'll give you exactly 1 minute.
Thank you.
I can't see it.
Dr. Agni, you can start sharing your screen meanwhile the participants are responding to the poll.
You want me to share my screen? Okay. And just give me a prompt when I can start then talking. Yeah.
Sure.
Yeah, sure, sir. Five more seconds. Thank you, everyone. Over to you, Dr. Saha.
Sure. Yeah, as you requested, so a very brief sort of, basically did my basic graduation here in RGCOR, then went over to UK. All pediatric intensive care training was in UK because pediatric intensive care was non-existent at that point of time. I did my pediatric intensive care in 4 different hospitals in Queen's Medical Center in Nottingham, St. James's in Leeds, then Royal Manchester Hospital in Manchester, and finally Birmingham Children's Hospital in Birmingham. Came back. I was in UK for about 2 years. So let's. So today we're going to talk on ventilator graphics. First thing first, I'm assuming basic understanding. Don't worry about that. I'll show you many graphs. None of them are originally made by me. They are all taken from different sources from the internet. Now, why this talk? Why graphics? I have seen that the graphic generates a lot of interest, and a lot of people want to understand and sort of learn it, as if there is something mysterious about it. And we'll see if we can sort of sort out some of these mysteries. But is it absolutely necessary? Although I'm doing this talk, I don't really think so. You can reasonably ventilate a kid without knowing much of a ventilator graphics. So it is not absolutely necessary. But how does it help? Well, clinically, it helps you hyperinflation about detect autopip. This is possibly the one thing which you cannot do otherwise, which you cannot do if you don't look into the graphics. So I think this is possibly one of the most
Dr.
important.
Saha,
Yeah.
sir, we cannot see your screen. Can you please try sharing your screen?
You cannot see my screen. Oh, how is it? Hang on.
Your video and your
Oh, I
screen
have
both are turned off, Dr.
your entire screen. Oh, share. Share. Why is it not happening? Share your screen. Entire screen. Share. Cancel. Let me cancel it. Meeting alert.
Do you want us to
Let me
share
just
the
try.
screen?
Let me just try once
Sure.
more. Let me just.
Please close your,
Is it?
minimize your presentation and stop sharing and then reshare.
Uh, yeah. Is it now visible?
No,
It is still not visible.
you have to close
Share
the
your
preview.
screen.
Please close the preview of the presentation and then share your screen and then you can
Close the. Close the presentation altogether. Yeah, I have completely come out of my
Sir,
presentation.
we'll share the screen. Piyush, can you share, please?
sure.
Where is it?
Yes, we have.
সে স্ক্রিন আছে সে হচ্ছে না কেন কে জানে
Dr. Saha, I can present it from my side. That's okay.
So if you can unmute yourself and uh, guide us on which slide we need to go.
Unmute. Start video. Yeah. Can you just go to full screen and yeah, I'm there. Just go to full screen. I'm there. Yeah. Okay. No, next slide, please. Next slide, please. Yeah. So yeah, as I was saying, why we need to know about ventilator graphics. As I've said, it is not absolutely necessary, but it is absolutely essential to identify auto PIP and avoid. No, no, no. Same slide. Previous slide, please. Yeah, I will tell you to go to next slide when I need it. Yeah. Okay, so so that is possibly the one thing very important. Besides that, it also helps to fine tune your settings, minor changes, but that may help to avoid patient ventilator asynchrony. That is one thing. Uh, it can also help you to troubleshoot, to figure out what is going wrong, monitor whether your patient is going better or going worse. But most importantly, this is although it is the last point, but I think it's very important that if you understand graphics well, then that actually boosts your understanding of the whole process of ventilation. What is happening inside the machine? What is happening within the patient? It really, really augments your understanding. Next slide, please. Next slide, please. Can I have the next slide, please?
So it takes 1 or 2 seconds to switch. That's from the Zoom. So just
yeah. So let us recap a little bit of physics, and this has been made easier by the two previous talks yesterday. You all know about this. If you have any fluid, and remember, gas is a fluid. If you have any fluid, then there has to be a pressure difference or a pressure gradient to have flow. If there is no pressure difference or no pressure gradient, there will be absolutely no flow. And as you all know, fluid always goes from a high pressure zone to a low pressure zone. And also the amount of flow is directly proportional to the difference in these two pressures, or the pressure gradient. So amount of flow is proportional to the pressure gradient. And what is flow? Flow is nothing but the amount of fluid going through a certain point of time per unit time. So how much fluid is going? That is flow. Next slide, please. And then a bit more physics, and this again all of you know, resistance. So whenever you talk about resistance with a fluid flow, you have to have a pipe. So when a fluid is going through a pipe, the pipe offers some resistance, and that resistance is proportional to the pressure gradient and inversely proportional to the flow. If you rearrange that, then you get the famous equation: pressure is equal to resistance into flow. So this is a very important equation, and please remember this: pressure equal to resistance times flow. Now in ventilation, this resistance comes from the circuit and also from the airways of the patient. The other thing is compliance. What is compliance? Compliance is nothing but a delta V by delta P, so change in volume per change in unit pressure. If you rearrange that, then you get the equation P is equal to V by C, where V is the volume of the lung and C is the compliance. So if your compliance is low, as in a pneumonia lung, where your lung is tight, your compliance is low, then to get the same amount of volume, you will need higher pressure. So the second equation of importance, P is equal to V by C. So P is equal to pressure is equal to resistance into flow, and pressure is equal to volume by compliance. Next one, please. Yeah, and what are the variables that we'll be working on when we're talking about ventilator graphics? There are only 4 variables. One is pressure, the other is flow, the third is volume, and the fourth is time. Now remember, volume is basically flow time integral. Volume is nothing but flow times time. So volume is a derived variable, the ventilator measures pressure, flow, and time, and from flow and time, it derives volume. So these are the 4 variables that we'll be working on. Next one, please. So, I don't know this. Uh, yeah. So first of all, we'll talk about scalars. So when you talk about scalars, that means in scalar on the x-axis, you always have time. And as the time only moves forward, the scalars only move forward. So naturally, you can have only 3 different types of scalars: pressure versus time, flow versus time, and volume versus time. So these are the 3 scalars we'll talk about. Next one, please. So we are starting, we'll talk about scalars first, then we'll talk about loop, we'll talk pressure control first, then volume control, and we'll try to figure out the differences. Next one, please. So this is our first scalar, the most easiest to understand. So this is a pressure time scalar. So as you can see, on the x-axis you have time, on the y-axis you have pressure. So this is a pressure time scalar, and this is for a PC breath, for a pressure control breath. So for a pressure control, what do? We set a PWP, we set a PIP, we set a TI or inspiratory time, and we set a TE or an expiratory time. So what happens, as the inspiration starts, the ventilator ramps up the pressure up to PIP and keep that pressure for the entire duration of inspiration. As the inspiration finishes and you go to expiration, the pressure drops from the PIP to PWP, which is almost never zero. So that is what happens in PC breaths. So this is what is happening. As you can see, as my inspiration has started, my pressure has gone up to this level. So this is my PIP. It continued for this duration. So this is my TI. As the TI ends, my pressure drops to this level. So this is my PWP, and then it continues at that level for this time. So this duration is my TE, and then the next breath starts, so on and so forth. So this is how a pressure time scalar looks like in PC breaths, and we call this pattern a square window pattern. So in PC breaths, you get a square window pattern. Now remember, this does not never actually happens in reality, because no machine can actually bring the pressure instantaneously from this level to that level. All machine has a response time. So this happens over some period of time. So this usually looks like a bit this rather than straight way like this. Okay. So next slide, please. So this is what just I was talking about. So you can see this is a pressure time scalar, and my pressure is going up and then staying there and then going down. So this is again a pressure time scalar for a PC breath. But what is this? What is this? This is the patient trigger. As we talked about yesterday, what happens when, if nothing is happening, even during expiration, a bias flow happens within the circuit. As the patient tries to breathe, if the patient has respiratory effort, as he tries to breathe, a little bit of air goes into the patient. As a result, the flow inside the circuit drops, and after that, the pressure also drops. And the ventilator can identify either of them and then realize, yes, my patient is triggering, so it delivers a breath. So that is what has happened here. The pressure has dropped a little bit, and the ventilator realized, yes, my patient is triggering, so it has delivered the breath. Next slide, please. Now, this is a very important slide, and this is the flow time scalar. As you can see, this is flow and this is time, and this is a PC breath, and this is how it looks like. Why? Just think about it. You are at the end of your expiration. So the pressure inside your machine is PWP, PEP, and the pressure inside the patient's lung is also PWP, PEP. Now your inspiration starts. As your inspiration starts, the pressure in the machine suddenly becomes PIP, which is much higher than your PWP. The pressure inside the patient's lung is still PWP. So we have a gradient. How much is the gradient? PIP minus PWP. We call this pressure the driving pressure. Now, as we have a gradient, so now air flow starts to flow inside the patient's lung. As air goes into the patient's lung distends. As the patient's lung distends, the pressure inside the patient's lung now have increased a little bit. So it is no longer at PEEP, but a little bit higher than PEEP. However, it has still not reached PEEP. So now still we have a gradient, but the gradient is now a bit less than before, because now the gradient is not PIP minus PEEP, but PIP minus something more than PEEP, because pressure inside my lung is a bit more. So my gradient has gone down. If my gradient goes down, what happens to my flow? My flow comes down, but it is still positive. So now still some air is going in, but it is going at a less faster. So my flow has gone down a little bit, but my pressure, but as air is still going in, the lung is still expanding. So the pressure inside the lung keep going up. So the gradient keeps going down. So the flow keeps going down. And this continues happening until the pressure inside the lung is also PIP. What happens then? The pressure inside the lung is PIP. Pressure at the machine is PIP. So there is no gradient. So the flow stops. So as you can see, the flow is a decelerating pattern. It continuously goes down until it reaches a baseline. So there is absolutely no flow here. And then as my TI ends, my expiration starts. Now, I would like all of you to take a deep breath and then expire. And also notice there is a gap between inspiration and expiration. Even if you try, can you go into expiration immediately after your inspiration stops? And also taking a deep breath, try to figure out what is the flow pattern, how is the flow happening. Take a deep breath, everybody. I hope as you have done so, I hope all of you have understood that the flow pattern physiologically is also decelerating, and you cannot go to expiration straight away, right? So, and that is exactly what happens in pressure control. So that is why we say in pressure control, the flow pattern is decelerating, very important, and it is a very physiological. So this is just consider them together. So this is a PC breath. This is a decelerating flow pattern, zero flow, and this is the pressure. And then, so yeah, next one, please. Now let us talk about volume time scalar for PC breaths. So what happens as air keeps going inside my lungs, the volume of my lung keeps going up, until we reach the zero flow stage. As we reach the zero flow stage, what happens? The lung is distended, but it is just staying there, distended. My expiration has not started. So that is what happens here. As you can see, my volume goes up as my air goes in, and this is, I am still in inspiration, but I have no flow, so my volume has not gone up. So I have reached a plateau, and then my expiration starts. Next slide, please. So that is about pressure control. And now let us talk about volume control. And in volume control, we'll consider flow time scalar first. So what happens in volume control? You sort of dial a tidal volume and you dial a I time. Suppose you have dialed a I time of 1 second and a tidal volume of 500 ml. As you do that, what the machine does? The machine does, okay, 1 second, 500 ml. So that means in 30 seconds, in 1 minute, how much? 50 into 30. So that is about 500 into 30. So that's about 30 liter. So I need to generate a flow of 30 liter per minute and keep that flow on for 1 second. And by doing that, I'll be delivering 500 ml. That simple calculation is done by the ventilator and it delivers the flow. So the flow remains constant through the inspiration. That is why in BC, as your inspiration starts, your flow goes up and then it stays there constant until the end of inspiration, and then your expiration happens. I have not talked anything about the expiratory flow previously, but it's important to know that this, because number one, whatever is your mode, your expiration is always passive. So the expiratory flow is always same whether you are PC or VC, and it is again a decelerating flow. But let's come back to VC. So the most important point here is in BC, the flow time scalar is a square window scalar. Yeah, this is like a just like a pressure time scalar of PC breath. So in BC, the flow time scalar is a square window. Next, please. So we have got two pressure time scalars. This looks like a pressure window. This looks like a decelerating flow. So this is pressure control. This is volume control. That's all very good. But this look, have a closer look at this one, and it looks a bit different. Why? My pressure has gone up, and then it has remained constant, and then it has dropped down. But my expiration has not started yet. I have got a bit of time there, and then my inspiration has started. So I have got a bit of time when there is no flow. The flow is zero, but my expiration has not started. This is T pause. So if you are doing BC, if you are doing volume control, then you have a choice of adding a T pause into it, or you may not want to do it. Why is it there? Because as we have said, we physiologically, we always have a little bit of gap between my inspiration and expiration. So to make a VC breath more physiological, we often incorporate a T pause in VC, whereas that T pause is inbuilt in a PC breath, provided your TI is long enough. So that is how a flow time scalar looks in VC. It is like a square window. Next one, please. And this is a bit complicated, unfortunately, but it has to be like that. So this is how a pressure time scalar looks like in a VC breath, provided you have a T pause. So this is a pressure time scalar in VC breath, provided you have a T pause. So what happens? As my inspiration starts, air keeps gushing into my lungs. So the pressure inside my lung goes up, goes up, goes up, goes up. So it has reached there. So this is my peak pressure. Now my I time has stopped and my T pause has started. So as my T pause starts, what is happening to my lung? My lung is still expanded, but there is no flow. But what happens to my pressure? My pressure suddenly drops to a certain extent and then stays there till the end of the T pause. And as my T pause finishes and I cycle to expiration, then my pressure goes down to the level of PWP. So in BC, rather than having two pressures, we have three pressures. We have one peak pressure, one PEEP, but we have one more secondary point here, and this pressure is called the plateau pressure. So why does this happen when this was not happening in PC? Why do we have it in VC? Why do we have two different pressures? We'll see that later. We'll see that now. Next, please. Next slide, please. Yeah. So this is a flow time and a pressure time scalar for a VC breath with a T pause. So as you can see, my flow is going up and my pressure is going up. And then this is where my pressure has gone down. So this is my T pause and my pressure has dropped down to plateau. So now let's first consider this point. At this point, what is my pressure? My pressure, as you have already talked, my pressure is volume by, for compliance, it is V by C. And for flow, it is resistance times flow. I don't know why it is a query there. It should be flow, resistance times flow. So for this point, my volume, whatever is the volume of my lung, that volume is there, and whatever is the compliance of my lung, that compliance is also there. So I have got a definite V by C, and whatever is the resistance of that lung and the circuit, I have got that. And then on top of that, I have got this amount of flow. So I have got resistance into flow. I have, for this also, I have got something. I've got something for this and something for this. Now let us consider the plateau point. At this point, what is my pressure? What is my volume by compliance? What is my volume? My volume is the same. No air has gone in, no air has gone out since the last time. So the volume is the same, my compliance is the same. So this amount remains the same. What happens to the other component? My resistance has remained the same, but what is my flow now? My flow is 0. I have no flow here. So for this amount, I don't have anything. I only have this amount. So previously I had this amount. Now for this amount, I have only 0. So that is why this pressure is less than this pressure. And it is less by how much? It is less by resistance into flow. So this drop depends on my resistance. And this is why if you the P peak for a same lung, for the same tidal volume, the PIP for a VC breath will be higher than a PC breath. Suppose you have got a lung, lung, same machine, you have set a tidal volume of say 500 ml. If it is on VC, you will see you are needing a peak pressure of say 24. But you change over right then at that point, you change over to PC and go up on your PIP till you reach your tidal volume of 500. You will see that it is not 24. It will be somewhat less than that, maybe 21 or 22. That is because of why. What happens? Basically, the plateau pressure and the PIP for PC breaths will be the same. The other thing to understand is this drop happens. Why? This drop happens because of this portion, because of resistance. So the higher the resistance, the bigger will be the drop. So the difference between PIP and P plateau will be higher if the resistance is higher. Next slide, please. So the same. So this is how a P pressure time scalar looks in a VC breath with inspiratory pause. Next one, please. So if the area under the curve is the work of breathing, then we can say this is the amount of work that we need to overcome the resistance, and it is the amount of work that we need to overcome the compliance. Next one, please. Next slide, please. Yeah. And as I've said, that if you have if you are ventilating an asthma, say, then you can see that this drop is very high. And actually, this is the difference between your P flat and P peak is actually an indicator of how severe the obstruction is. And as your patient gets better, this difference goes down. Whereas if you are dealing with a patient with low compliance, pneumonia, then both your P peak and your P flat will be high. So it will look like this, and the difference will not be high, will not be big. Next one. So here I've got all three. So you can look into, let's go directly into flow. So this is a square window. So this is volume control. This is a decelerating pattern. So this is pressure control. Pressure control. So this is the pressure time scalar for VC breath. This is the square window for pressure time scalar for a PC breath. Yeah, everyone is happy. It's amazing that you don't get feedbacks, yeah, but let's move on. Next slide, please. Now, what is the difference? So here I have two different breaths. Let's have a closer look at them and let us figure out what is the difference. Number one, this is a pressure time scalar. Pressure time scalar looks like a square window. So this is a PC breath. But what is the difference between these two? The peaks, these levels are same, but as you can see, this is much longer, this is much shorter. So here, so this breath is much shorter. Number one. Let's go to the flow time scalar. Here also we see, yes, it is longer, it is shorter, but there is one more difference, and that's a very significant difference. Here it is touching the baseline, whereas here it is not touching the baseline. It was there, it has not touched the baseline, but my expiration has started. So what is this breath? This is what we call a supported breath. As you know, if it is a supported breath, then in a supported breath, for a controlled breath, how long does the inspiration last? The inspiration lasts for TI, which you decide. You set a TI and it goes on for that. For a supported breath, how does the ventilator decide how long to continue the inspiration? and that depends on the something called the flow termination criteria, and which is usually set somewhere around, it is a percentage. It may be 80%, it may be 60%, something like that. So suppose you have set your flow termination criteria as 80%. So for a supported breath, what happens? This is my peak pressure, sorry, this is my peak flow right at the beginning of the ventilation. So this is my 100%. As my inspiration goes up, it goes down, 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 down. As it grows down by 80% or it reaches 20% of the original, then if you set it at 80%, then the ventilator will cycle to expiration and it will start there. If your flow termination criteria is 60%, then it will go down, 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 down up to this level maybe where it is 60% and my expiration will start. So this is a supported breath. In a supported breath, your flow never touches your baseline. Where it starts depends on the flow termination criteria. In many ventilators, you can actually set the flow termination criteria as you wish, and in some ventilators, you cannot set it. It is set by default. And as you look into the volume curve also, look here, because we have a zero flow state, so we have this plateau phase and then the expiration. Here you do not have a zero flow phase, so you do not have this plateau. So it goes and then drops down straightway. So in a supported breath, the time will be less, the flow will never reach the baseline. On the volume curve, you will not have the plateau. This is how a supported breath looks like. Next one, please. What is happening here? So this is a pressure time scaler and it is square window. So it is something to do with, it is a pressure controlled. But look at this flow time scaler. None of the flow curves actually touching the baseline. None of them. Okay. So it looks like all of them are supported breaths. One other thing is, remember, all supported breaths has to be patient triggered. All patient supported breaths has to be patient triggered. So, and that is not very obvious here, but if you have the sort of, they are often color coded. So if there was a color code, you could see that all of them are triggered breaths. So then basically what is happening, all the breaths here are all supported breaths. So what mode it is? It is CPAP PS. Yeah, you only have supported breaths and nothing else. Next one, please. Next one, please. Yeah. So this is more of the same. So you can see none of the pressure of the flows are reaching the baseline and they are pressure controlled. So this is again a CPAP PS. And you see, look, the volume, none of them has the plateau. Next one, please. Now we have something else. So what is this? So this is a pressure time scaler. Okay. So this is my PWP, and then my pressure is gradually going up. So what type of breathing it is? It is a volume control breathing. Yeah. If it was a pressure control, it would be look like a square window. So it is a volume control. Now remember, in volume control, you have a fixed flow. The ventilator decides on the flow. Now, if your patient have a lot of air hunger, if he wants to breathe very hard, then what happens? Sometimes the flow that the machine is generating may not be enough for the patient. Okay, the flow that the patient is generating may not be enough, and if that happens, then the patient is having air hunger, and then what happens? This curve, rather than looking like this, it sags and it looks like this. It looks like this. So if this happens in a volume control pressure time scaler, if you see the sagging, that tells you that your patient is having air hunger. Next slide, please. So the same is happening. This one, the flow is good. Here you can see it is sort of sagging. So we have a bit of flow deprivation. So if this happens, what can you do? The best solution is change over to PC. In pressure, you have unlimited flow. And if your patient is having this much of air hunger, most likely his drive is pretty good. So rather than going to, you can either go to PS. I will rather go to PC. I will rather go to just PS. Just go to pressure support, and all this asynchrony will simply go. Next one, please. This is again a pressure time scaler, and you can see that this is happening. And then what is happening here? we have very little time for the plateau. So my plateau is not at all happening. It's just happening and going down. So I have inadequate T pause. If this happens, then you need to increase your T pause a little bit. Next one, please. This is a volume time scalar. Okay, so your volume is going up, 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 and then we don't have a plateau phase, and your expiration starts. So maybe it is a sort of volume control without a T pause. But what is important here is you can see the volume is coming down, but never quite reaching the baseline, and then the next one starts. It never quite reaches the baseline. So my expiratory volume does not quite reach there. So what is happening? This is happening because of leak. So when you have a leak, your volume time scalar does not reach the baseline. So there is a leak somewhere, maybe in the tube, maybe in the circuit. Next one, please. Now then, setting appropriate I time. How can you decide that? So what is this? So this is a flow time scalar, and it is decelerating. So it is a pressure control breath.
And you have 15 minutes.
Okay, and so this is the pressure control breath, and this is the volume time scalar. You can see that we are delivering about 450 cc. Now what it could be, it can well be a supported breath as we have talked about, but then it has to be a patient triggered. No, yeah. So it has to be a patient triggered. But suppose you see that it is not really patient triggered, it is a controlled breath, but it is happening there. So what is happening is basically your I time is simply not long enough. Your I time is not long enough. That is why your flow has not quite reached the baseline. If it is important to avoid this. If you are having this, all you need to, what you can do, you can just go up. You can just increase your I time. You need to increase your I time here. And go to the next slide, please. Next slide,
Dr.
please.
Saha, I'm giving you remote control so that you can change your slide and also use your pointer, because participants are asking if you could use your pointer and point to the specific point.
I am pointing. Can't you see it? Oh,
No,
I am. I can
sharing
see it. No, you cannot. Oh dear me, dear
also,
me, dear
you
me.
have 7 minutes more.
The pointer is very important. I don't know why I couldn't. Pointer was so important.
We can see it. You can use it now.
How do I use that? How do I control that?
It's visible.
We can see the pointer moving, sir.
You can see my pointer moving?
Yes, yes, sir.
Okay. And for the next slide, what do I do?
Just click on the right side of the screen.
Which bit? Why don't you change it? Why don't you change it? Just give me the pointer. You keep changing the screen, changing the slides, okay?
You have the controls, so we cannot do it parallelly.
Where
just click on the right hand side very quickly.
Here?
Yes.
Right hand side means what? Oh.
It's working.
Okay. And I go back there?
Yes.
No, it is. Oh, it is going.
You'll have to move to the left, sir. Right. Yes.
Okay. So as you just increase your I time, please give me a couple of minutes extra for this. So
absolutely.
as you increase my I time, now as I increase my I time, now my flow is reaching my baseline, and my volume has also gone up to 500. And remember, you did not have to go up on your PIP. So just by increasing your I time, you are increasing your tidal volume rather than giving more pressure, which is good for your lungs. Next one, please. Oh, sorry. Yeah. Now, what is now let us look into the expiratory bits. Expiratory phase. What is the difference between these two? Here you can see this is my peak expiratory phase, peak expiratory flow. Yeah, and here this is my peak expiratory flow. You can see that the peak expiratory flow is much less here than here. And the other thing is the expiration is ending here, whereas here it is taking much longer. So my peak expiratory flow is less, and I am taking much longer to end my expiration. So this is an obstructed lung, which happens in asthma, and also sometimes if you have some fluids in your expiratory limb or something like that. So this is how an obstructed expiration looks like. Next one. Yeah, and this is very important. Please pay attention here. So this is again sort of respiratory. Let's forget about this bit. Let's just look at the expiratory bit. So what is happening? My peak expiratory flow is very low, and I am very obstructed, and I am taking a long time for expiration. But this is the most important bit. My expiration has not ended, but my next inspiration has started. So this is what you call a dynamic hyperinflation, and this is what happens in bad asthma. So what is happening here, for every breath, your expiration is not ending, but your next inspiration is starting. For every breath cycle, you are keeping a little bit of air inside your lung. All of the air is not going out. And as it keeps happening cycle after cycle, so your lung becomes very distended, and then after some time, it is just not possible to push in any air into the lungs. So this is called dynamic hyperinflation, and this happens in asthma, and this is something very bad. So it is very, very important, if you're ventilating a patient with asthma, make sure that the expiratory flow reaches the baseline. If it does not reach it, then you have two options. Either you can increase your I time, or you can decrease your tidal volume, or sometime you may need to do both. What is happening here? The same thing. And this is something you cannot identify unless you look into the flow. And this is how auto-PEEP happens. So as your lung becomes very expanded, so the pressure inside lung becomes more than PEEP. How do you identify auto-PEEP? You need to go to an expiratory pause. If you go into an expiratory pause, the pressure inside your lung at the end of expiration should be equal to the PEEP. But if it is more than the PEEP, then the difference between your applied PEEP and what you are finding is the auto PEEP. So suppose your PEEP is 5 and you have gone for an expiratory hold and you are getting a pressure of 10, then your auto PEEP is 10 minus 5, that is 5. And auto PEEP tells you how bad the obstruction is. Right. And that brings us to loops. We will not talk much about loops. In loops, you do not have time. So you only have 3 variables. In theory, you can have 3 different types of loops. That pressure flow loops are never used. So pressure volume or flow volume. In pressure volume, volume is in y-axis. In flow volume, volume is in x-axis. So this is a pressure volume loop. So this is my inspiration and this is my expiration. Okay, so look what is happening. This is my trigger, but as my volume starts increasing from here, and all through it my pressure remains the same. My pressure remains about 20. So all through the increase of volume, my pressure is the same. So this is a PC breath, and this is my expiration. So this is how a pressure volume loop looks in a PC breath. Whereas this is a VC breath. Again, this is my pressure, this is my volume. As you can see, as my volume is going up, so is my pressure going up, unlike the previous one. So my pressure and volume goes up together. So this is a VC volume pressure loop, and this is my expiration.
So 4 minutes.
Yeah. And this is a PV loop. And how we use, so suppose I have got a lung. The PV loop was looking like this dotted line before, and now it is looking like this. So the PV loop it looks as if it is trying to lie down and it is going towards the x-axis. So if that happens, what does it mean? Consider this point. So previously at this point, my pressure was somewhere over there and my volume was somewhere over there. But now on this new loop, for this point, my pressure remains the same, but for the same pressure, my volume is much lower. Okay, so for the same pressure, I'm having much less volume. So what is happening? My compliance is going down. So as your compliance is going down, the PV loop will go towards the x-axis. So that tells you that the lungs is getting worse. And this is hysteresis. So, and the area within the curve is the work of breathing that you need. But as you can see, suppose it was like this before. It was like this, and then it has become like this. So what has happened? The area within the loop has increased. So your work of breathing has increased. But look into the how much it is mostly in the expiratory part. In the inspiratory part also work of breathing has gone up, but much more in the expiratory part. So this happens in an obstructed lung. In an obstructed lung, the PV loop widens. And what is happening here? It is again a PV loop. Your pressure is going up, and then this part, you can see your pressure is going up, but your volume is hardly moving. So your pressure is going up, your volume is not going up. So you are basically hyper expanding this lung. This is very bad for your lung. And here you are creating a lot of pressure unnecessarily without having any volume. So if you have a lot of beaking, then you must make sure that you back off your pressure. You need to bring your pressure down. You are causing a lot of harm to this lung. And what is happening here? Your inspiration is going up, and then your expiration is going down, but it is not coming down all the way. So this is a leak. This is a leak. Here again, leak. This is the last thing. This is a flow pressure, flow volume loop, flow volume loop. So this is my flow, this is my volume. So what is happening? My flow is going up all the way, and as my volume is increasing, my flow is constant. So what sort of breathing it is? It is a VC breathing. Yeah. So my volume is going up, but my flow is constant. So it is a VC breathing, and it is a flow volume loop for a VC breath. And what is this? You can see my pressure is going up, my flow is going up, and then as my volume is going down, my flow is coming down. As my volume is going up, my flow is coming down. So I've got a deceleratory flow. So what is this? So this is a PC breath. Yeah, because my flow is decelerating as my volume is increasing. And here my flow is touching the baseline. So it is a controlled breath. This is another loop, again decelerating flow, but my flow is not touching baseline. So this is a supported breath. So this is a pressure controlled flow volume loop. This is a pressure supported flow volume loop. This is my peak expiratory flow. This is my peak expiratory flow. What is wrong here? Look into the expiratory phase. That my peak expiratory flow is very bad, and it looks like scalloped and taking a lot of time. So this is an obstructed expiratory flow. This is an obstructed expiratory flow, as you can see in a flow volume loop. This is more, this is basically, sort of how it, if you have an asthma, this is a control. Let's forget this. So this is obstructed. You can see the peak expiratory flow is not much, and it looks like this. Whereas you have given some salbutamol, you have given some bronchodilator, and it looks like this. So my peak expiratory flow has gone up a lot, whereas previously it was there, it is here, and it looks much better. So response to bronchodilator. And this is again a flow volume loop. But this is expiratory time, it is not quite reaching zero. So what is happening here? There is a leak. This is a leak. What is happening here? Again, a leak. So enough is enough, I think. And that's why we have come to the end of it. I'm ready for questions. Thank you for the extra time.
Thank you, Dr. Vishekar Shah, for the fantastic presentation. It was very, very informative. We are still waiting for the questions. So,
if anyone has any questions, can raise their hand or can post it on chat.
Or otherwise, we can just go straight to the next session and then we can do the questions at the last.
Yeah, if there is no question, I'm surprised.
Well,
So
I think it's because it's for graphics. Without drawing, people can't ask many questions. Without drawing it.
and I think for big part of it, the pointer was not working. I did not quite understand that. Okay.
Yeah.
So shall we go on, move on to the next session then,
Yeah.
rather than wasting
I
time?
think so. I think so. So, I'll just switch on my video. Today is on pulse oximetry and capnography, the two most important monitoring for a ventilated patient, because as you all understand that ventilation is all about adequate oxygenation and adequate carbon dioxide removal. So in order to monitor the adequacy of mechanical ventilation, it is essential to develop an understanding, an in-depth understanding of these two specific monitoring, these two specific monitoring modalities, along with the science behind it and the information it provides, and what are the pitfalls. And to take us through this session, we have our very young and dynamic Dr. Satyabrat Roy Choudhury. Dr. Satyabrat Roy Choudhury is an MD in general pediatrics and has been an asset to the PICU of Medical College Kolkata, where he is currently attached as a clinical tutor. Dr. Mihir and Dr. Satyabrat, they are together the backbone of the pediatric intensive care service of Medical College Kolkata, and he's also the in charge of the pediatric asthma clinic of Medical College. So over to Satyabrat, please. Satyabrat, is there?
Yes, yes. Dr. Satyavrata, you will have to unmute yourself.
Okay, am I audible?
Yes, sir.
Dr. Satyabrat, you are now
Thank you,
co-host.
Subha.
You can share your screen.
Can you share my slides?
Do you
No,
want to do it
so
from your end? We have made you a
we'll have to
co-host.
share screen, Piyush.
There is a problem, so please share your screen, please.
Just a second, please. You can control the screen now, Dr. Satyabrat. You can change it from your side.
Thank you.
Please go on the right-hand side of the screen and click.
Slides are not showing.
Piyush, it's not switched on. We cannot see the screen.
Dr. Satyabrat, please let me handle the screen. You have the control. Just give me 1 minute.
Okay.
So Dr. Saha, we are getting messages in the chat saying that this was the best lecture ever. So I guess we should give Dr. Saha a round of applause for the lecture, and saying that they want to hear it again. So
I think
thank you so
they
much,
have
Dr.
lost a
Saha.
lot of, because if that pointer was not working, I mean, I don't know why my slideshow didn't work, and without the pointer it is very difficult to understand. So maybe they did not quite get the full benefit of the lecture. I'm very sorry for that.
Yes. Dr. Satyabrat, please give me a second, and yes, you can do it now.
Okay.
Please go ahead.
Previous slide. Can I go back? Okay. Okay. Thank you. Thank you. Today my subject is monitoring of oxygenations that is done by mostly SpO2 monitoring. That is we know that. Previous slide, please. Okay. Uh, Clinically, it is very difficult to monitor hypoxia clinically because most appropriate clinical sign, most sensitive clinical sign to detect hypoxia is central cyanosis. And central cyanosis is something that is developed very late. When the saturation is below 70%, then below 70%, then we can get central cyanosis. So you know, you can imagine that is very late. Okay, so we cannot wait till that. So we are monitoring pulse oximetry, and it is considered as fifth vital sign. Okay, so it is a very non-invasive method and very easy to do. Pulse oximetry has a sensitivity of 92% and specificity of 90% at the level of 90% oxygen, 92% oxygen saturation. So it's a very sensitive one. Now, there are lots of indication of pulse oximetry as it is a fifth vital sign. You can monitor any patient who needs respiratory monitoring. We use this pulse oximetry. You can use it in emergency room. You can use it in labor room. You can use it for minor OT procedure, OT, general or anesthesia during general anesthesia, during some small procedure sedations, and also in our ICUs. Okay. Now, oxygen saturation, what does it mean? It means that the hemoglobin is currently, the ratio of hemoglobin currently bound to the oxygen to the total hemoglobin level. There are another thing that is SaO2. SpO2 is quite different from SaO2. SaO2 is an invasive one, and SpO2 is our normal pulse. SpO2 is done by pulse oximetry, and SaO2 is done by blood gas analyzer. Okay, so there are two types of blood. We are using some normal blood gas analyzer that we use in our ICUs. They usually don't measure it; they just calculate it with the help of our oxygen hemoglobin dissociation curve. They just put the PaO2 and find out the corresponding SpO2 from that. And for measuring actual SaO2, we need a co-oximeter. And it is sometimes very important to have a co-oximeter, because if we want to do a SpO2 monitoring in case of shock, or if we want to estimate that we want to believe our SaO2, and we must have a co-oximeter. So this picture is showing pulse oximeter probe. Accurate.
Dr. Satyabrata, you will have to unmute yourself.
Yes, thank you. This is showing a normal pulse oximetry probe applied over a finger. Okay, there are two types of probe we have. That is one is transmitter type. That is one side there is a transmitter, and one side there is a receptor. And there is only reflective type. They're both of these are placed on same side. Okay. So this type of transmitting probes are applied generally over the fingers, and it can be applied over the earlobes, and in case of newborn, it can be applied over heels. Studies have shown that the changes in SpO2 it can be catched more quickly in earlobe than fingers. Okay, and reflective probes can be applied on flat surfaces like our forehead and our chest, above the chest. The main basic basic character estimation, basics of the estimation of the SpO2 is based on two basic principles. One is the partial one is the absorption, partial absorption of characteristics of the oxygenated and deoxygenated hemoglobins of in red and infrared lights. And so generally the oxygenated hemoglobin usually absorbs more infrared light, and deoxygenated hemoglobin absorbs more red lights. When this ratio, both we can calculate SpO2 with this absorption ratio of in red and infrared light. When both of them are equal, then the saturation red is to infrared ratio is 0.5, then SpO2 is considered 100%. And there are another thing that is more that is another important thing. Previous slide, please. Previous slide.
So you'll have to click to the left.
Forwarding. Can I cannot get to the previous slide. It's just that's okay. So another thing is that modulation of the impending light with the pulsatile flow of the arteries, that is very important, because there are in tissue there is some pulsatile arterial blood, there is non-pulsatile arterial blood, non-pulsatile venous blood and tissue. All of these things are absorbs absorbs lights. Okay, but this pulsatile, this portion, this is a photoplethysmograph. If you consider this as a photoplethysmograph, this distance is absorbed by the pulsatile flow. This is called AC, and this distance is absorbed by the non-pulsatile flow. This is the systole and this is the diastole. The ratio of this AC and DC is called pulse index. Okay, so with the help of this pulse index and differential absorption of the infrared and red light by the oxygenated and deoxygenated hemoglobin, we usually calculate this SpO2. And this is the normal plethysmograph. It is very important to have, when you are recording a SpO2 on a monitor, it is very important to have a normal plethysmograph, because this normal, if you don't have this normal plethysmograph, it is that number is showing in the monitor may not be correct at all. There are some in the second picture you can see the patient, the perfusion of the patient is very low, so the curves are flattened. In this situation, the accuracy of the SpO2 is lower. And the third picture is showing that noise artifact. This noise artifact created when you loosely feed the SpO2 over the hand of the patient. Okay, and third one, the fourth one, that is most important in pediatric, that is motion artifact. This motion artifact has to be is a very problem for the pediatric and newborn patients, because patients usually moves their hand very frequently. This age group patient moves their hands very frequently, and with hand movement there is accuracy of the SpO2 is also lowered. To correct this, there are different patent technology for different, like Nalcor and Maxims have their own patent technology for modifying this error. Now, there are some factors that reduce the accuracy of the pulsating signal, like nail polish, pigmentation of the skin, high intensity ambient light, excess patient movement and motion artifact, as I have mentioned, decreased perfusion and presence of normal hemoglobin, presence of abnormal hemoglobin like carboxyhemoglobin, intravascular dyes, and reduced accuracy of the of SpO2 also reduces with the fall of saturation. So at high saturation it is more sensitive, and low saturation is less sensitive. There are some conditions there we can get a false normal or false high reading, like carboxy hemoglobin, that's CO poisoning, because carboxyhemoglobin absorbs light at 660 nanometer, that is red light, and it is similar to the oxyhemoglobin. So it mimics like oxyhemoglobin and gives a false high SpO2 in case of carbon monoxide poisoning. Now, there are some conditions there we record false low reading, like methemoglobinemia, sulf methemoglobin, sickle cell hemoglobin. This methemoglobin and sulf methemoglobin also absorbs red light and infrared light, both type of lights, and different amounts, and they also affect the reading. So we get inaccurate low reading. Now, PaO2, what is PaO2? PaO2 is the partial pressure of oxygen, that is a dissolved oxygen in the plasma. The solubility coefficient of O2 is 0.003 ml per dl. So what does it mean? It means at a normal PaO2 of 100 ml mercury, only 0.3 ml per dl is physiologically dissolved old oxygen. So there is a complex relationship between PaO2 and SaO2. That is called this curve is S-shaped curve is called there is a S-shaped curve is called oxygen hemoglobin dissociation curve. Usually at 100 PaO2 there is hemoglobin saturation is also 100%. As the one hemoglobin molecule usually binds with 4 oxygen molecules. As one by one hemoglobin oxygen molecules binds with the hemoglobin, there is structural change of hemoglobin, and with each structural change, affinity towards the next oxygen molecule also increases. So affinity for the 4th molecule is highest. So that is the reason upper part of the curve is flat. Upper part of the curve is flat. So it is up to 60 PaO2. There is minimal change of SpO2 with the fall of PaO2. This is a physiological buffer also in this region. So if PaO2 falls up to 60, there is minimal change in SpO2. Then there is a steep part. In this steep part, with minimal change in PaO2, there is a huge fall in oxygen saturation. So this part is also very important. In case of hypoxic patient, if we increase PaO2 very little in saturation, so that also saves the patient. This is the oxygen delivery equation. We know this is the DO2 means the total of oxygen delivered. That is the cardiac output into arterial oxygen content. The arterial blood oxygen content is equal to that total oxygen in the hemoglobin and the dissolved oxygen. You can see that the dissolved oxygen is very small amount, and huge part is that this part is the main part. Okay, and this is 1.34 comes. This is called Hafner's constant. This is 1 gram of hemoglobin carries 1.34 ml of oxygen when fully saturated. Okay, so this is important. Why why PO2 estimation is important? Because PO2 estimation is very important because this indicates the diffusion capacity of the lung. If, we know that in ARDS we find FaO2 by PaO2 ratio. If it is less, if we calculate, and it indicates that the diffusion capacity of the lung. Okay, but consider that if the patient hemoglobin is also very important part. It plays a very important role. In a patient, if there is saturation is normal and also PaO2 is also normal, but hemoglobin is very low, but then the arterial blood oxygen content will be very low. Thank you. The content will be very low also. So in that case, we have to use the patient to save him. Now, my next topic is capnography. So, SpO2 gives us idea about the oxygenation of the patient. But for carbon dioxide removal, we have to depend on the PO2. And we know that PO2 is an invasive thing to estimate, and it is not possible to do ABG all the time. So if we have some surrogate marker for PCO2, then it will be very helpful. And capnography can play some part in this regard. Okay. So these are capnography is the graphical representations of the expiratory air carbon dioxide, and it is estimated mainly by these two methods. One is the mainstream method and one is the side stream method. This is the mainstream method. In this case we estimate that expiratory air carbon dioxide with calorimetric method, and with this instrument we can this side stream method, we just take a sample of the expiratory air and analyze it inside the monitor. Both have some advantage and disadvantage. These things looks and it is difficult to attach, and in this case this pipeline may be choked by the humidifications. Okay, so we have to attach this part between patient PT tube and ventilator circuit.
Dr. Satyabrat, please, we are giving you 5 more minutes. You can take your slides a bit slow. That's okay. Please take 50 more minutes. You can do it as per your time. That's okay with us. No issues.
Okay.
Yes.
Okay. Thank you. Now, utility of the ETCO monitoring. There are different utility of ETCO monitoring. That is to confirm the ET positions to patient. It is used for patient transport when we are intubating a patient and we are transporting. It is very important to secure the ET in position. For that reason, we can attach ETCO2 to this patient and monitor that ET is attached or not properly. Then it is a surrogate marker that I have told you previously. It can help as surrogate marker for continuous monitoring of PCO2. And effective, it is also used in case in case of CPR. We can see that the CPR is effective or not. Estimation of dead space, I will discuss it later. And there are other implications. I will also go further. Okay. So there is ETCO2, normal ETCO2 level is 35 approximately, and it can there is a normal difference between the ETCO2 and PCO2. It is not equal, and it reflects that VQ mismatch. So normal difference is for 2.225 ml, but it is not fixed. It can vary with patients. We usually estimate it for every patient and every time we do ABG. So whenever we do ABG, we note that PO2 and we note that time at the ETCO2 at that time, and we find out the PO2 ET difference here. So this curve is showing that this is the norm. This is the normal thing. Okay, so carbon dioxide is a gas that diffuses very quickly through the our alveolar membrane. So our venous blood contains PaCO2 of 46, and when it comes to the alveolar capillary, it quickly equalizes with the alveolar air. So alveolar air almost contains 40, and alveolar capillary also contains 40. But this cursor is not moving. So, but the part that dead space part is not yes. This part air in this part of this our airway does not take part in air exchange. So this part contains very little amount of CO2. So when the alveolar air goes up mixed with the dead space air, the ET2 value reduces. Okay, so the alveolar CO2 is 40, but we get ET 38. Now, Suppose there are some conditions, there is some embolization or something happened, and this part of alveolus is not getting any blood. So this part is compromised of perfusion, but ventilation is occurring. So this alveolus will act like dead space. So air inside this alveolus also don't take part in air exchange, also contain very minimum amount of carbon dioxide. On the other hand, this part of alveolar will contain 40. So it will go and mix with this air, and EQ will be around 20 to 18. So there will be difference. This difference is increased by 22. This why this difference increased? Because of this dead space. Okay. Now another scenario here. This part of the lung is not ventilated. So blood coming through these alveolar capillaries don't take part in air exchange. So they are containing higher amount of carbon dioxide. So they will go and mix with this part of blood, and total PCO2 will be PCO2 will be high. On the other hand, this will be this will be the EtCO2. So the difference between PCO2 and EtCO2 also will increased, and this difference is due to increase in the PCO2. Now, there are different phases of capnograph. This is the phase. Normal capnograph looks like a square wave, and this is the first phase. In this phase, this is the start of expiration. At the start of expiration, the air comes out. It usually comes out from our dead space. So it contains very minimum amount of PCO2. Then next part. In this part, the alveolar air get mixed with the dead space air. So there is a steep rise of CO2 level, and then there is a flat part. This is the alveolar expiration. In this part, this is the height. This is the point. This is the CO2 point. Okay, so this value we estimate, and at this point, the inspiration starts, and at the start of inspiration, EtCO2 falls very quickly. Now, this is the normal square wave form, and normal EtCO2 is 35 to 45, and now we are seeing some abnormal situation. So suddenly we are monitoring a patient, and suddenly there is flat wave in our flat EtCO2 wave in our monitor. So what should we do? We have to go through our ABCD approach. Okay, so we have to check for the airway. ET tube is in position or not. The patient is ventilated by the machine or not, and C, that is most important, patient is maybe in cardiac arrest also. So we have to check for ABC, and then we have to check for the equipment that the EtCO2. Sometimes the patient is okay, but the EtCO2 device maybe clogged with moisture or secretion, and for that reason you are getting the flat wave. But first you have to check patients. Okay. So this is in case of CPR, this is esophageal intubation. Whenever we are intubating, we usually check that intubation is successful or not by auscultating or seeing the wrist. But the most definite way to check that intubation is successful or not is putting a EtCO2 device between your back mass and your ET tube. Okay, if you find a square wave, then your intubation is successful. But if you are finding this type of flat thing, then you may have put the ET tube in the esophagus. Now, during CPR, if we can attach our EtCO2 device during tube bagging, so between tube and bag, then if we can find that ETCO2 wave is showing 10 to 15 millimeter of mercury things, then our CPR is adequate. We are giving adequate amount of chest compression. But if it is below 10, then adequate chest compression is not provided. So we have to change the rescuer if he has got fatigue. Then during CPR, suddenly there is rise of ETCO2. Then we have to check for circulation. It is a sign for return of spontaneous circulation. Now, in case of hyperventilation, we will find that there will be short waveforms and ETCO2 level will be less than 35. Okay, and in case of hypoventilation, there will be prolonged waveform and ETCO2 level also will be high. In case of obstructive airway disease, we find this type of sharp fin curves and rising of baseline. This is the baseline, and you are seeing that there is a gradually rising of the baseline. This is a sign of rebreathing. Okay, so patient is rebreathing, so we have to allow adequate oxygen flow. This type of curve, this type of narrow this type of curve is usually due to rupture. You put a small size tube in a patient, and the tube is leaking, then this type of curve can be seen. Now, the patient is in muscle relaxation, and when patient is weaning from muscle relaxant, you can find this type of cleft in the ETCO2 curve. Now, last of all, this is our estimation of physiological dead space. Okay, so I have told you previously the importance of doing whenever you are doing blood ABG, you have to note your PCO2 and you have to find out the difference between PCO2 and ETCO2. It is very important because suddenly you found that patient's PCO2 and ETCO2 difference has increased. That means there is an increase in dead space. So, what may be the causes of increase in dead space? That there may be some pulmonary embolism, or there may be hypoperfusion, or the alveoli are not taking part in air exchange, so there may be defect in the alveolar membrane. So we have to do accordingly the etiology, according to the etiology. But we can also estimate that dead space also with the help of this equation. This is the dead space volume, and this is the tidal volume. And if we multiply this tidal volume with difference between PCO2 and ETCO2 by PCO2, then we can get the dead space. Okay, this can also help to estimate that dead space, and we can estimate that dead space is increasing or decreasing, and we can adequately influence our therapy also. Thank you.
Thank you, Dr. Satyendra.
Hello. Thank you, Satyendra. It was a fantastic presentation. It was very informative. So, do we have any questions so far? Or
if anyone has a question, please raise your hand.
For any question, yes, please raise your hand or please type in the chat box.
So, there's a question from Shreya Chaudhary, causes of urinary notch. So that is for Satyendra.
So urinary notch are due to I have demonstrated that urinary notch patient is in full muscle relaxant and patient is getting out of muscle relaxant. So when there is fluctuation of ETCO2 due to the patient's own effort, these urinary notches are created.
I think there's one more question as well. That is from Chandri Bhattacharya.
Yes, we can measure ETCO2 in non-intubated patients also. We can measure it in a laryngeal airway also. And in case of a non-ventilated patient, we can measure ETCO2 with nasal, this is a device with nasal prong-like device. Okay, and I think I have not used it in non-invasive ventilation, but with that device, I can think we can use it in non-invasive ventilation also.
You've already explained about the Cura and Notch. There was another question from Jasprit Singh Raina. Please explain the Cura and Notch. Do you have anything else to add to that, or you've already explained that?
I have explained.
Photography is in newborn ventilation. Shushanto Kumar Shaha.
I can't understand the question. Repeat.
Yeah, how useful is capnography?
In newborn for a long time, but I think it can be helpful in newborn ventilation also. But it is
I will.
Hello.
Yeah, I think I'll answer this question. So basically, nowadays in the Western world, this capnography is a standard of care even for newborns.
Yes.
We are quite worried about using capnography or ETCO2 for newborns for two main reasons. Heavy kind of a gadget, so basically it always kind of put a risk of dislodging the ET. Given the size of the preterm newborn, it will be quite a big dead space. But nowadays, because of we use more of the side stream for newborns, which is much lighter and which is not that much of a dead space. That is kind of standard of care in most of the NICUs in the Western world these days. Previously, we used to use it only for transport, but nowadays we use it even inside the NICU as well. So the next question is, Ashoto, do you have anything else to add? Or do you have anything else to add?
Oh,
what
that's,
I say
that's
about? Okay. So next is from Ganga Prasad. It can be measured EPCO2 with non-invasive ventilation. Yes, we can use EPCO2 even for non-invasive ventilation, even for spontaneous breathing patient. So that can be done, yes. Shotto, are you listening? Or yeah,
yes,
so basically there's another one from Upasana Pasra, which is better out of which one is better out of co-oximeter and pulse oximeter?
Co-oximetry and pulse oximetry completely different thing. Co-oximetry is an invasive thing, and pulse oximetry is a non-invasive thing. We generally use pulse oximetry for everyone and co-oximetry for specific situations when we don't. It is also something that we don't use so frequently. Okay, so if there are some indications for specific indications for co-oximetry. Okay, so whenever we are dealing with some.
I mean, can I just can I add a few things to that? Yeah.
Yes,
so basically, a co-oximeter, most of the blood gas machines that actually measures the. So you can have two types of SaO2. One is a measured and so the blood gas machines which do not have a co-oximeter, what they do is that they generally measure and then they kind of look at the picture that pH and they plot that SaO2 that corresponds to it. So basically that's the measure, that's the calculated SaO2. On the other hand, if you have a co-oximeter, then it actually physically measures the oxygen saturation. So that is the gold standard. So basically, if your question is which one is better between co-oximeter and a pulse oximeter, there can be no doubt that co-oximeter is the gold standard. As for the pulse oximeter, above 85% when the RIR ratio is more than 1. So so below that, if it is this saturation is less, then the pulse ox becomes very inaccurate. So that's why all the cardiac units that actually uses a saturation below 85%, most of them have this co-oximeter when you say that it is 75, it might actually be 65. You do not know because you cannot actually make it out from just a. And the other thing is that with pulse oximeter, a good place is very, very important. So the next question is, Dr. Shah, do you want to add anything or hello?
Hello. The
No.
main thing is
No,
that
Dr. Shah.
I don't want to add anything. No.
Go ahead. Go ahead. Okay. Okay. Shotta was saying something.
If, at the low saturation, pulse oximetry is not that sensitive. So when we are dealing with patients that have low saturation, we have to rely on co-oximeter. Okay. And another thing is that when pulse oximeter readings are not, there are some errors in the errors in the pulse oximeter readings, like specific situations like that carboxyhemoglobin or methemoglobinemia, we have to rely on co-oximeter. So co-oximeter is for specific indication and pulse oximetry is for general indication.
There's some
We will take the last question, Dr. Satyabrat. Dr. Sanjay Kumar is asking, can we, Dr. Ajinkya Suryavanshi is asking, ETCO2 can be used reliably in HFOV, instead digital capnography is used. Can we use ETCO2 instead of digital capnography?
In case of high frequency ventilation.
HFOV, yes.
High frequency ventilation, digital capnograph. ETCO2 can, this is, I think, in case of high frequency ventilation, digital capnograph is more reliable.
I don't think we can actually use any kind of end tidal in high frequency because we do not have an expiratory phase at all. Okay. There is no expiratory phase. Dr. Shah, what do you think?
Yeah, I mean, you may get some number, but that number will not be reliable. That number will not be reliable. Yeah.
Piyush, any other questions that you want us to answer?
I think let's give participants an option to continue on the WhatsApp group. All faculty members can then respond there. Thank you everyone for joining us today. We will quickly share the endline poll before we finish.
We encourage all the participants to please post your questions on the group since we already extended over time. So please post all your questions, and our speakers for today will be surely answering them. And before we leave, I think Dr. Satyabrato, in spite of the technical difficulties, both our speakers, Dr. Saha and Dr. Satyabrato, delivered a really excellent session today. So we would like to give a round of applause to Dr. Satyabrato and Dr. Saha.
Thank you to both the
speakers. Thank you. Again, I don't know, the loss of the pointer was a big loss because my talk was quite heavily dependent on the pointer because it was lots of graphs and all. Can't help.
But sir, we have got comments that in spite of the pointer, they could understand most of it, and it was an excellent presentation. But yeah, they would want another presentation from you with the pointers very soon. So that's a suggestion that we've got from the participants.
Thank you, everybody. See you tomorrow.
Thank you, everyone. See you all tomorrow. we'll be keeping the WhatsApp group on till 10 p.m. So feel free to post any questions that you may have.
Yeah, if you have
Thank
any
you.
questions, keep posting there. We'll answer that. Me and Sattu will try to understand,
Yes.
answer that. Thank you.
Thank you.
Thank you.
And thank you, Bichitra, for moderating the session.
Yes, thank you, Mr.
Nobody
Sharma.
thanked Bichitra. What is that?
Thank you, Mr. Sharma.
Thank you.
Yeah.
Thank you, Dr. Rata. Thank you. Thank you, Piyush.
Thank you,
Thank you,
everyone.
Lakshmi.
Thank you, everyone.
Thank you.